So we're going to discuss for the next half hour or so three main topics here, which are chronic liver disease, which represented by liver fibrosis and cirrhosis in all its manifestations with complications. And then we'll discuss the MR appearances of fatty liver deposition, and then iron liver deposition. And then we'll finish the last few minutes by discussing some new perspectives in MR imaging for better characterization of diffuse liver disease. So I do mostly MRI, but do some CT, but I'd like to convince you that MRI is better than CT for evaluation of chronic liver disease. It's radiation-free, as you may know. Gadolinium is generally safe, non-nephrotoxic. MRI has a better contrast resolution and can easily detect iron and fat. You can use specific contrast agents with MRI on top of the regular gadolinium DTPA agents. You can use iron oxides to better characterize chronic liver disease to detect HCC. Some centers have experience in that. We don't use that, but you can use it. One of the latest contrast agents that came to the market recently is called Multihance and has some biliary elimination and can also be used to better characterize some focal liver lesions. You can do with MRI also direct imaging of hepatocarcinogenesis, as Dr. Lee showed you before. And generally, MRI has a higher sensitivity for HCC detection. There are very few studies that really directly compare the two modalities. One of them was from 2001. Generally, I will suggest that if you have to choose between MRI and CT, you'd rather do a good CT than a bad MRI. But if you have a good MRI and good CT, it's always debatable depending on your experience. But generally, MRI will give you more information about chronic liver disease. So our protocol in our institution, we use a T1 in and out of phase with the TE of 4.4 and 2.2 for 1.5 Tesla. So this is T1 weighted sequence, but it's also very sensitive to fatty deposition, iron deposition in the liver. We use some kind of T2, either a stir or a T2 fat saturated, a coronal T2, single shot T2 to look for any biliary or pancreatic ductal abnormality. And then we use a flow sensitive sequence, a time of flight sequence to look for portal vein patency and flow direction. This is a Grand Echo T2 star sequence, so it's also very sensitive to iron deposition because it has a long TE, approximately 9 to 10 milliseconds. And then we'll finish by using the dynamic 3D T1 Grand Echo sequence, which is called VIBE on the Siemens systems or LAVA on GE. We use a very thin section, 2 millimeters, and so we run this at least 4 times, so pre-contrast, arterial phase, portovenous phase at 60 seconds, and then at 2 or 3 minutes. We use a timing run on the aorta using 2 cc's of contrast, and the timing is really essential to detect HCC. Some examples here in and out of phase in a patient. This is the in-phase sequence. The out of phase is recognized by the India artifact around the edges with the fat, coronal haste or single shot T2, axial T2 with fat sat. This is the time of flight sequence, which is flow sensitive sequence where you saturate the flow superior to the liver, and you're going to see the IVC bright and the portal vein is bright, meaning that they're patent but also peel. The axial vibe at the arterial phase and the portovenous phase. So the whole protocol takes about 20 to 30 minutes. So let's discuss the MR manifestations of liver cirrhosis. So as you may know, liver cirrhosis is defined histologically by the association of fibrosis, advanced fibrosis, and nodules, usually regenerative nodules, but you can have also dysplastic nodules and HCC. The most prominent causes recently in the US and Europe were viral hepatitis. There's recently also an epidemic of HCV or chronic hepatitis C related to all these, post-transfusional cases in the 80s. HBV is also really prominent also. NASH or non-alcoholic steatohepatitis is also more and more recognized as an emerging etiology also for chronic liver disease. The other etiologies are listed here, including alcohol, primary biliary cirrhosis, PSC or primary sclerosing cholangitis, and hemochromatosis. Just remember that liver cirrhosis is a pre-malignant condition, so it carries a very high risk of HCC. So that's one of the roles of MRI or CT that you're doing for these patients. You're detecting HCC. That's the main thing you're doing for them. It carries also a high risk of end-stage liver disease, and the only cure for these patients is liver transplantation. And one of the role of MRI is really to decide whether a patient is a candidate for liver transplant based on the presence or not of HCC, and if there's any HCC based on the number and the size. This is a typical appearance of a cirrhotic liver on a T1-weighted sequence in phase, where you see a nodular appearance of the liver inside, and also the contour is irregular. You see some ascites around it, a big spleen. The explant correlation showing you also diffuse nodularity of the liver. So just to emphasize about chronic viral hepatitis, it's affecting about 3% of the world's population, 200 million people affected with chronic hepatitis C currently. And the prevalence is quite high in the US. It's rising, so it's about 5% for HBV and 2% for HCV. It's important to know that more than 2/3 of patients with HCV can become chronically infected, and there's a high risk of liver fibrosis and subsequent cirrhosis at the end. There's a difference between HBV and HCV in terms of risk of HCC. So the hepatitis B virus is oncogenic by itself. So you can see HCC in patients even without cirrhotic changes. So usually these patients are younger and they have usually larger infiltrative tumors, as shown in this study by Memorial Sloan Kettering. HCV virus is not oncogenic by itself, and HCC needs to be developed only after cirrhotic changes have been developed in the liver, and there's usually a lag time of 10 to 20 years after you can see HCC. But that doesn't mean when you see a patient with chronic hepatitis C, when it's first diagnosed, doesn't mean that the infection was recent. Infection usually happened years ago, depending on when the patient was transfused or had surgery. So the number of papers have described the MR appearances of cirrhotic liver. So there are a number of signs, but the main appearance is the appearance of the irregular liver contour, as I showed you before, a nodular or reticular appearance of the liver parenchyma. You can have also some morphologic changes, including atrophy of the medial left lobe. You can have also atrophy of the right lobe, hypertrophy of the left lobe, and this is extremely variable. The Dunn-Mitchell group have also described these signs in different papers, including the expanded gallbladder fossa sign, the right posterior hepatic notch sign. But remember that all these signs are usually present in moderately to advanced cirrhosis, and they're not sensitive. MRI, conventional MRI, including T1, T2, and gadolinium, is not sensitive enough to detect early cirrhosis. Typical appearance of a cirrhotic liver. This is a 3T. This patient was imaged with 3T magnet. You see the lobular appearance of the liver here with a notch here. This is called the right posterior hepatic notch sign by the Mitchell group. There is also increased amount of fat around the portal vein. This is also called the increased periportal hilar space. The other changes you're going to encounter with MRI include nodules in the liver. More specifically, there are multiple types of nodules, but main nodules you're going to encounter would be regenerative nodules, dysplastic nodules. It's very hard to differentiate these two. There's an overlap in appearance, and HCC, of course. Fibrosis can be diffuse or focal. You can have, of course, signs of portal hypertension, and a lot of times you're going to see lymphadenopathy around the porta hepatis or in the portocaval area. They're usually reactive in chronic hepatitis B and C. This patient had a typical appearance for confluent hepatic fibrosis on MRI, where you see this band-like appearance, high T2 signal retracting the capsule, typical for hepatic fibrosis with delayed enhancement at the equilibrium phase. So don't call this an HCC. HCC will never retract the capsule unless it's treated. The manifestations of portal hypertension MRI can be easily seen, usually splenomegaly, ascites. You can also detect and map the extent of shunting or varices in the splenomegaly area, gastroesophageal varices. You can see also recanalized paraumbilical vein and more rare appearances will be peripancreatic or intrahepatic varices or intramesenteric varices. The other signs include gallbladder and colon wall edema, which are extremely frequent in portal hypertension, partly due to hypoproteinemia, but not only. You can see also splenic iron deposition in the spleen called Gandhi bodies. Typical appearance of portal hypertension here in this patient with mildly cirrhotic liver with the big spleen, and you see here a dilated varix here. This is the left gastric vein, which measures more than 5 millimeters. Usually it should be measuring less than 3 millimeters in normal patients, and over 5 millimeters is a good sign of portal hypertension. Another patient here with also cirrhotic changes, and you see a recanalized paraumbilical vein, large spleen with splenorenal shunts here. Another patient with a large spleen, some ascites. You see a very atrophic liver, multiple extensive splenorenal shunts going into the left renal vein. Another patient also with a large amount of ascites. So I'm not going to spend too much time on description of nodules, but you can encounter dysplastic nodules in the liver, in the cirrhotic liver, that can be bright on T1, as told you Dr. Lee before. So these can be due to copper deposition, fat, or hemorrhage sometimes, or sometimes even Fe3+, like iron in the 3+ form, can be also giving bright signal on T1. It's very hard to appreciate any enhancement at the arterial phase, and you need to do some kind of subtraction between these two images to make sure that the lesion is not enhancing. So typically, dysplastic nodules and regenerative nodules don't get any arterial phase enhancement. However, there are some reports about high-grade dysplastic nodules getting arterial phase enhancement, and there's a spectrum of appearances either at histology and MRI between high-grade dysplastic nodules and well-differentiated HCCs. HCC typically is bright on T2. This is classic, but however, this is not really the case. This is a case of a cirrhotic liver where you see extensive fibrotic changes, bright on T2, and you see a more focal lesion here adjacent to the right portal vein, better seen on the T2 fat sat or stir than on the haste sequence. Again, the arterial phase timing is essential for HCC detection. This is a cirrhotic liver with a enhancing lesion in the right lobe of the liver that you can completely miss on the portal venous phase. HCC. So MRI would not only diagnose liver cirrhosis, portal hypertension, will also diagnose any HCC or dysplastic nodules, but also you can help the clinician by identifying some specific etiologies of chronic liver disease using MRI only. So let's review those. We'll review the iron and fat at the end. So PSC, or primary sclerosing cholangitis, can have some features of parenchymal atrophy or cirrhosis. Typically, patients present with intrahepatic biliary ductal dilatation. Sometimes it can also affect the CBD. Typical appearance of strictures with a beaded appearance here. You see a stricture in the CBD. Same patient has also intrahepatic biliary ductal dilatation with a beaded appearance with multiple strictures, and you see parenchymal atrophy in the right liver lobe. You can have also nodules in the liver, and there's a high risk of cholangiocarcinoma, of course. And these patients, if you identify the patient in advance, you need to do a delayed acquisition of 10 minutes to identify any delayed enhancing lesion in the porta hepatis. There's another patient with PSC with an MRCP, thick slab, and ERCP correlation. We see multiple strictures of the CBD again, and also intrahepatic biliary ductal dilatation with multiple strictures typical for PSC. Chronic Budd-Chiari also, we do see some patients from time to time. It's not as frequent as in Japan, but these patients typically have hepatic venous occlusion or thrombosis. Sometimes they can have also portal venous occlusion. Typically, they will present with collaterals. They have also features typical for Budd-Chiari, which include early peripheral enhancement, because the portal venous blood to the periphery of the liver is compromised. You can have also hypertrophy of the caudate lobe, and you can have also cirrhotic changes, of course, in advanced cases. There's a risk of HCC. However, the risk is probably lower in the US and Europe than in Japan. Typical appearances. This is an arterial phase image, axial T1, where you see arterial phase enhancement in the periphery of the liver. This is a T2 showing you a nodular liver, a little bit, globular in appearance with the small ascites. You see only one vein here on the right, which is a little bit tortuous, abnormal in appearance. The delayed venous phase shows you only probably one abnormal vein. There is no other vein. There is no middle vein and left hepatic vein. And on the coronary format from the T1 weighted sequence at the venous phase shows you multiple collaterals in the liver. This is typical for Budd-Chiari. We see from time to time also patients, usually women with primary biliary cirrhosis. This is usually a histological diagnosis. Patients have problems with their intrahepatic ducts, but very, very small. So usually these patients don't present with any biliary distension unless they have concomitant disease. And this sign has been described in this paper in 2001 as relatively specific for this disease. It's called the periportal halo sign, where you're going to see at the portal venous phase or the delayed phase a halo decreased enhancement basically around small portal veins here. And this is probably related to periportal hepatocellular necrosis, as stated in this paper. So let's move on now to the description of MRI appearances of liver steatosis or fatty liver disease. So I'd like to show you first this slide where recent papers, at least 2 or 3 papers, have shown that there is an increased risk of HCC in NASH or non-alcoholic steatohepatitis, but also in patients with obesity and diabetes, at least 3 recent papers. This is a case we encountered recently, a patient who had a diffuse fatty liver disease with a little irregular liver here. There's a more focal lesion that dropped more than the rest of the liver. I don't know if you see it from here. This lesion was slightly bright on the T2, very subtle increased signal on T2. And the arterial phase shows some enhancement of that lesion. So this was suspicious for HCC. This was proven by biopsy to be an HCC. A patient had NASH. So now remember that these patients have also an increased risk of HCC, and a lot of cryptogenic cirrhosis were probably related in the past to this kind of disease, to fatty liver disease. So why is it important to recognize this etiology? Because as you probably know, non-alcoholic fatty liver disease can affect 30 to 100% of obese adults, and we all know that there is an epidemic of obesity in the U.S. The non-alcoholic fatty liver disease has a wide spectrum, from simple steatosis, simple fatty deposition, to non-alcoholic steatohepatitis, which is the end of the spectrum. And we know that these patients carry high risk of fibrosis and end-stage liver disease, up to 25% of these patients. This is a typical appearance of fatty liver deposition on a biopsy. So the etiologies of fatty liver disease are multiple. These include, again, obesity, diabetes, chemotherapy, and alcohol. Why is it important to diagnose fat? Because, for instance, in patient population composed by liver donors, you need to identify any fatty liver disease, because we know that more than 25% of fat in the liver, when transplanted, can cause any liver transplant failure, basically. Patients with, again, diabetes, obesity have high risk of irreversible liver dysfunction. And MRI can be used also to monitor treatment in these patients. So the typical appearance is usually diffuse, can be uniform or geographic, can be focal or multifocal. So when it's focal, usually the location is around the gallbladder or segment 4 or the falciparum ligament. And a lot of times it's kind of wedge-shaped, irregular shaped. It's usually homogeneously enhancing. And sometimes you're going to see blood vessels going through the lesion. This is a typical appearance of a diffuse fatty liver on the inner outer phase. Just like to remind you that the outer phase uses usually a TE of 2.2 milliseconds, and it's kind of subtraction between the signal from fat and water in the voxel. So all voxels containing some mixture of fat and water will drop in signal. You see diffuse fatty infiltration by, you see diffuse signal drop of the liver, and you see this area of fatty sparing in the medial right lobe. Another case here with a in an out-of-phase image showing you also diffuse decrease in signal with some areas of fatty spattering in the caudate lobe and around the portal vein, typical appearance. I'd like to show you this. This is not really a diffuse liver disease, but it's a nice case of focal steatosis, typical location around the portal, the falciparum ligament or around the portal vein, where you see nothing on the in phase. You see a clear lesion measuring about 2 or 3 cm in the outer phase. You can see some kind of, on the T2 fat side, you see a little bit, lower signal than the rest of the liver. And this was enhancing like the rest of the liver on the post-contrast images. From time to time, you're going to see also patients with multinodular steatosis, which is kind of rare but happens, especially in patients with chronic hepatitis C. This patient had abnormal LFTs and had all these innumerable small hyperechoic lesions on ultrasound. And this was worrisome for anything, for hemangiomas, for small adenomas, or could be also fat, multinodular fat. So the patient had in and out of phase. You see nothing on the in phase, but you see ill-defined signal drop here on the outer phase. This is the signature for multinodular steatosis or multinodular fatty infiltration. There was ill-defined enhancement there, but this patient was followed, and this was all by itself. So the next topic we'll discuss is abnormal iron deposition in the liver. So we know that iron is a metabolite that can cause a lot of disturbances in the liver, can cause liver fibrosis, can cause also, it's a pre-cancerous also, it's an oncogenic element in the liver, so it can cause HCC also in patients with primary hemochromatosis. So you can easily detect and quantify also iron deposition in the liver with MRI, with some specific sequences. So the most sensitive sequences are the T2 star sequences or granite echo T2, because you have an increased magnetic susceptibility when you have iron deposition in the liver. This will cause spin dephasing and a signal loss basically on these T2 star sequences. So usually the best sequence to detect iron in the liver, there's a nice study from last year by this group from France where they use multiple T2 star sequences with different echo times, and the most sensitive one that correlated better with the amount of liver in the liver was the T2 star with the longest TE. So one needs to differentiate different types of iron deposition in the liver. So the main two types are primary hemochromatosis, which is a genetic disease, versus hemosiderosis, or some people call it also secondary hemosiderosis or secondary hemochromatosis. I usually use the term hemosiderosis. So this is, again, genetic disease. It's about 0.5% of the Caucasian population infected. Hemosiderosis is acquired usually by multiple transfusions. Can be seen also patients with thalassemia with transfusions also. Can be also seen in, we don't really know why, but cirrhotic patients, cirrhotic liver can also have abnormal iron accumulation. The organs involved are, that's big difference between the two. So for primary hemochromatosis, liver is involved, but also the pancreas and the heart can be involved, giving symptoms like diabetes and abnormal cardiac function tests or cardiac insufficiency. And usually at histology, the iron is present inside the hepatocyte. For hemosiderosis, usually the iron is present in the Kupffer cells or reticuloendothelial system deposition, and it does not affect the pancreas or the heart, usually not, unless it's a very advanced disease, and usually goes into the liver, the spleen, and the bone marrow. So that's a way you can differentiate these two entities. The risks are, there's a very increased risk of end-stage liver disease in patients with primary hemochromatosis and HCC. Patients with hemosiderosis also have a small risk of fibrosis. There is no, to my knowledge, no risk of HCC in patients with hemosiderosis alone, excluding, of course, any associated etiologies like chronic viral hepatitis. So this is a typical appearance of primary hemochromatosis. You can use the in and out of phase sequence because the in phase has a longer TE than the outer phase, about 4 milliseconds at 1.5. And you're going to see a diffuse signal drop on the in-phase sequence, which is in this case kind of diffuse, but also more nodular with some siderotic nodules with small ascites. This is the sequence I showed you before, which is the time of flight sequence, and shows you also a diffuse signal drop of the liver. This is a signature for iron deposition in the liver. The patient had also a history of genetic hemochromatosis. So these patients need to be followed every 6 months to 1 year to make sure there's no HCC developing in the meantime. This patient had also primary hemochromatosis, as seen here, as a diffuse signal drop of the liver on the in phase, and the patient had also a small focal lesion here at the lateral left lobe, which has caused some bleeding around it. This is an HCC in a patient with primary hemochromatosis. This patient had a history of multiple transfusions. I believe he was also had chronic renal insufficiency. And you see the difference with the other patient. The other patient didn't have any, we don't see the spleen, but didn't have any iron deposition in the spleen. But you see clearly that this patient had iron deposition in the spleen and the liver. You see a signal drop of these two organs on the in-phase sequence, signature of usually secondary hemosiderosis. As I told you before, you can have also abnormal deposition of iron in the liver in cirrhotic liver. And this can be seen as what we call siderotic nodules, so there's some controversy about the risk of HCC. Two papers in literature, one said that there is increased risk, the other one said no. The one that said no was from our department, from Dr. Krinsky. So we don't think in our department that an increased amount of iron in the liver increases the risk of HCC. A neurotypical appearance with a T1 in-phase sequence where you see a lot of tiny innumerable hypointense nodules, and the histology correlation shows you the Prussian blue here with increased iron. So I'll finish the last 2 minutes by showing you some new perspectives and new technology you can use to better characterize diffuse liver disease. So in our department and other people also have been working on using diffusion-weighted imaging, which is a technique used usually for stroke detection, to detect lesions and also try to quantify the amount of fibrosis in the liver. So we already showed that there is a decreased diffusion coefficient that you can measure using this sequence in cirrhotic livers. So this is a typical appearance this is a cirrhotic patient, and this is a normal volunteer. And so cirrhotic patient had ascites, and this is the acquisition using multiple B values. I don't want to go into the details, but basically you can quantify the amount of diffusion inside the liver. And in this particular case, you see that the diffusion coefficient was pretty low as opposed to the normal volunteer. Okay, let's do this. So we've been also using recently perfusion-weighted imaging to try also to detect early cirrhotic changes. We know that the liver has a dual blood supply, so it's a very complex blood supply, 2/3 from the portal vein, 1/3 from the artery approximately. And this, of course, changes when you have cirrhotic changes. You have increased arterial flow into the liver called the buffer response. This is related to collagen deposition or fibrosis in the space of this, which is the space located between the hepatocyte and the blood vessels. So this is what we do. Typically, we do a coronal acquisition, a 3D turboflash sequence. We use a 2 or 3 minute acquisition with a high temporal resolution, and we keep scanning the patient. So we get multiple arterial phases, porvenous phases, and delayed phases, and we can quantify the amount of blood going into the liver. This is a patient who had a large FNH in their liver in the left lobe. Also, you can also quantify the amount of blood going into the lesion also. So we use some kind of complex mathematical modeling. Basically, this is the liver, so 2 input and a single outflow, basically. And you can use all these parameters that you can quantify. You can quantify the amount of arterial flow going to the liver, the porvenous flow. You can quantify the transit time of contrast from gadolinium into the liver. You can also look at the distribution volume of contrast, and you can look at the time to peak of contrast, like you do, for instance, for brain tumors. So we showed this recently. This was presented at the RSNA this year, that there was a significant difference in all these parameters between patients with no fibrosis and patients with some degrees of fibrosis to the spectrum of cirrhotic changes. This is a nice picture showing you a color map of the time to peak, basically. So you see here a normal liver, and this is a cirrhotic liver. You see a very large difference between the two. This is in this liver, there's an increased time to peak in the liver, and can quantify that also easily using these color maps. You can use also spectroscopy or hydrogen spectroscopy to quantify and detect fat deposition in the liver using what we call the single voxel spectroscopy, which is a single volume that you can put in the right lobe, for instance, and you can easily detect and quantify changes in normal spectra by looking at the peaks of fat and water. And this is a potential non-invasive, it's like a vitreal biopsy, basically. So this is a recent case we had at 3T where you see a diffuse signal drop on the outer phase and the corresponding spectroscopic image showing you equal amounts of fat and water. This is the fat peak and this is the water peak. And you can quantify easily the fat fraction basically using this technology. Normal volunteers, including myself, no fat in the liver, which is good. So very tiny, there's less than 5% fat in normal volunteers usually. Okay, let's finish by looking at iron quantification. So these slides were given to me by Dr. Jensen, who's been actively working on quantifying iron in the liver. So you can use some multi-echo T2 sequences to quantify the total amount of iron in the liver, but you can also separate the two types of iron, which is hemosiderin and ferritin, and you can try to quantify that, and he's actively working on that. So there's a lot of potential in this type of research. So I'll conclude my talk by saying that there is a wide range of disease in diffuse liver disease. And you have to know the MRI and try to be comfortable with MRI techniques and the limitations. Most of these diseases will give you high risk of end-stage liver disease and HCC. And functional MRI has some promising results. Thank you for your attention.